Good morning or good afternoon to all. Me and my partner, Mr. Suerte, will be reporting to you the different venous disorders. But before we continue, we would like to ask you one question. What do you know about these disorders? And how will we student nurses, or I'd rather say future nurses, would deal with these different venous diseases? To start, let me share to you the basic overview of the venous system. The venous system refers to the network of veins that work to deliver the oxygenated blood back to our hearts. The veins are a type of blood vessel that return the oxygenated blood from your organs back to our heart. These are different from our arteries because the arteries delivers oxygenated blood from your heart to the rest of our body. Then, the deoxygenated blood that flows into your veins is collected within tiny blood vessels called the capillaries. The capillaries are the smallest blood vessels in our body. Oxygen passes through the walls of our capillaries to our tissues. And then, carbon dioxide can also move into our capillaries from the tissue before entering our veins. In short, the venous system is like a cycle that helps in hemodynamics. As we've said, we had listed some venous disorders for us to share. We have the venous thromboembolism, chronic venous insufficiency or post-thrombotic syndrome, leg ulcers, and varicose veins. Venous disorders can alter the transport or flow of the blood from the capillaries back to the heart and make changes in smooth muscles and connective tissues. And it also allows the valves to malfunction, causing backflow of the blood. Deep vein thrombosis and pulmonary embolism collectively make up the condition called VTE, or venous thromboembolism, and are considered as a single disease entity. Deep vein thrombosis tends to occur at the bifurcations of the deep veins, which are sites of turbulent blood flow, and it is also a major risk during the acute phase of thrombophlebitis. Pulmonary embolus is also a serious complication arising from DVT or deep vein thrombosis of the lower extremities. DVT can be manifested through these clinical manifestations. We have the pain and edema of the extremity, increased circumference of the thigh or calf, and human sign can be felt. With the presence of the clinical manifestations, it is important for the nurse to assess for the characteristic of the pain, the onset and duration of symptoms, the history of thrombophlebitis or venous disorders, color and temperature of extremity, and the edema of calf and thigh by using a tape measure to measure both legs for comparison, and lastly, to identify areas of tenderness and any thrombosis. For the diagnostic evaluation, we have only two techniques. One, the invasive techniques, which includes the Doppler ultrasonography, duplex venous imaging, and the impedance plethysmography. For the invasive techniques, we have the eye-labeled fibrinogen scanning and the contrast phlebography. To continue, the objectives of treatment for DVT are to prevent the thrombus from growing and fragmenting. Medical management requires hospitalization, which includes bed rest with legs elevated to 15 to 20 degrees above the heart level, which knees are slightly flexed and trunk horizontal, and also the head may be raised, to promote venous return and to help prevent further emboli and prevent edema. It is also important to apply warm moist heat to reduce pain because it promotes venous return. And also the use of elastic stocking or bandage. For the pharmacologic therapy, we have the anticoagulants, fibrinolytics, and vasodilators because they are needed to control vessel spasm and improve circulation. Surgery is necessary if the thrombus is recurrent and extensive, or if the patient is at high risk for pulmonary embolism. These surgery procedures are thrombectomy, or incising the common femoral vein in the groin and extracting the clots. And we also have the vena cava interruption, which is a transvenous placement of a grid or umbrella filter in the vena cava to block the passage of emboli. For the nursing interventions and preventive care, it is important for the nurse to encourage the patient to prevent long periods of standing or sitting that impairs venous return. It is also important for the patient to elevate his legs when sitting to prevent venous pooling. And if edema occurs, elevate legs above heart level. Regular exercise program is also important to promote circulation and also to avoid crossing legs at the knees. Avoid wearing constrictive clothing such as tight bands around socks or garters, and the use of stocking or elastic stocking on the affected leg is prohibited. Leg exercises during periods of enforced immobility, such as after surgery, is important as well. In nursing management, the nurse is encouraged to provide acute care like explaining the purpose of bed rest and leg elevation, the use of elastic stockings, to monitor the patient on anticoagulant and fibrinolytic therapy for signs of bleeding, and to monitor for signs of pulmonary embolism. Because pulmonary embolism has sudden onset of chest pain, dyspnea, rapid breathing, and tachycardia. Another example of venous diseases is the chronic venous insufficiency. Chronic venous insufficiency results from the obstruction of venous valves in the legs or the reflux of blood back through the valves. Superficial and deep leg veins can also be involved. Clinical manifestations of chronic venous insufficiency or post-thrombotic syndrome are characterized by chronic venostasis resulting in edema, altered pigmentation, pain, stasis dermatitis, and superficial veins may be also dilated. Venous ulceration is the most serious complication of chronic venous insufficiency. Cellulitis and dermatitis may complicate the care of CVI and venous ulcerations. Medical and nursing management for CVI is directed at reducing venous stasis and preventing ulcerations. Measures that increase venous blood flow are anti-gravity activities such as elevating the leg to decrease edema, and it promotes venous return and also provides symptomatic relief. Compression of superficial veins with graduated compression stockings reduces pooling of venous blood, enhances venous return to the heart, and it is also recommended for people with venous insufficiency. Extremities with venous insufficiency must be carefully protected from trauma by keeping the skin clean, dry, and soft. Signs of ulceration are immediately reported to the primary provider for treatment. That is all for the venous thromboembolism and the chronic venous insufficiency. Now, Mr. Suerte will now report about leg ulcers and varicose veins.
So, as you can see, it is presented on the screen the brief anatomy of human leg. Leg ulcers is an excavation of the skin surface that occurs when inflamed necrotic tissue slows off. In the United States, the most common lower extremity lacerations have a venous etiology, estimated between 45% and 90%, with PAD the second leading cause. The coexistence of both venous and arterial disease is estimated to be present in 26% of patients with leg ulcers. Pathophysiology of leg ulcer. The inadequate exchange of oxygen and other nutrients in the tissue is the metabolic abnormality that underlies the development of leg ulcers. When cellular metabolism cannot maintain energy balance, cell death results. Alterations in blood vessels at the arterial, capillary, and venous levels may affect cellular processes and lead to the formation of ulcers. This is the characteristics of arterial and venous insufficiency resulting to ulcers. In the arterial, tip of toes, two webs, heel, or other pressure areas if confined to bend. Very painful. Deep, often involving joint space. Circular. Pale to black and dragon green. Minimal unless extreme, kept in dependent position constantly to relieve pain. In the venous, medial malleolus, lateral malleolus, or anterior tibial area. Minimal pain if superficial or may be very painful. In depth of ulcer is superficial, irregular border, granulation tissue, beefy red to yellow fibrinous in chronic long-term ulcer, and moderate to severe. The assessment and diagnostic findings. The history of the condition is important in determining venous or arterial insufficiency. The pulses of the lower extremities, the femoral, popliteal, posterior tibial, and dorsalis pedis are carefully examined. More conclusive diagnostic aids include Doppler and duplex ultrasound studies, arteriography, and venography. Medical management. Patients with ulcers can be effectively managed by advanced practice nurses or wound ostomy continence nurses in collaboration with the patient's primary provider. All ulcers have potential to become infected. The nursing process. Assessment. A careful nursing history and assessment are important. The extent and type of the pain are carefully assessed, as are the appearance and temperature of the skin of both legs. The quality of all peripheral pulses is assessed, and the pulses in both legs are compared. The legs are checked for edema. If extremity is edematous, the degree of edema is determined. The patient nutritional status is assessed, and the history of diabetes, collagen disease, or varicose veins is obtained. The diagnosis. Impaired skin integrity related to vascular insufficiency. Impaired physical mobility related to activity restrictions of the therapeutic regimen and pain. And last, imbalanced nutrition, less than body requirements related to increased need for nutrients that promote wound healing. The planning and goals. The major goals for the patient may include restoration of skin integrity, improved physical mobility, adequate nutrition, and absence of complications. The nursing interventions are the following. Monitor status of skin around wound, monitor patient skin care practices, noting the type of soap or cleansing agents used, temperature of water, and frequency of skin cleansing. Next is keep a sterile dressing technique during wound care. Premedicate for dressing changes as necessary. Check every 2 hours for proper placement of footboards, restraints, traction, casts, or other devices, and assess the skin and tissue integrity. Educate patient about proper nutrition, hydration, and methods to maintain tissue integrity. Instruct patient, significant others, and family in the proper care of the wound, including hand washing, wound cleansing, dressing changes, and application of the topical medications. Evaluation: patient demonstrates restored skin integrity, exhibits absence of inflammation, exhibits absence of drainage, negative wound culture, avoids trauma to the legs. Also increases physical mobility, progresses gradually to optimum level of activity, discusses with family members dietary modifications that need to be made at home, reports that pain does not impede activity, attains adequate nutrition, select foods high in protein, vitamins, iron, and zinc, discusses with family members dietary modifications that need to be made at home. Last, plans with the family a diet that is nutritionally sound. So this is the last venous disorder in our presentation. The varicose veins. The varicose veins are abnormally dilated, tortuous, superficial veins caused by incompetent venous valves. Most commonly, this condition occurs in the lower extremities, the saphenous veins, or the lower trunk, but it can occur elsewhere in the body, such as esophagus. So it will be presented in the screen. The venous anatomy of the legs. The presentation is the light blue is the deep system, and the dark blue is the superficial system. Pathophysiology. Varicose veins may be primary without involvement of the deep veins or secondary, resulting from the obstruction of deep veins. A reflux of venous blood results in venous stasis. If only the superficial veins are affected, the person may have no symptoms but may be troubled by their appearance. The symptoms of the varicose veins, if present, may include dull aches, muscle cramps, increased muscle fatigue in the lower legs, ankle edema, and the feeling of heaviness of the legs. The assessment and diagnostic findings. It includes Doppler ultrasound scan, which documents the anatomic site of reflux and provides a quantitative measure of the severity of valvular reflux. These scans are typically performed in a reverse Trendelenburg position or with the patient standing. Also, CT venography can be helpful. It includes injecting of radiopaque contrast agent into the leg veins so that the vein anatomy can be visualized by X-ray studies during various leg movements. Medical management. The most common treatment options for venous insufficiency and varicose veins are surgical ligation and stripping, microphlebectomy, and a foam sclerotherapy. The pharmacologic therapy. The following list of medications are in some way related to or used in the treatment of these conditions. These medications are polidocanol, Asclera, Sodradicol, Varetana, and sodium tetradicyl sulfate. The nursing process. Assessment for varicose veins are the following. Assess the degree and types of pain, the level of activity, movement disorders, the causes, signs, symptoms, and effects of movement disorders. Assess the quality of peripheral pulses. Check the edema and the degree of edema, especially in the both lower limbs. Next is the diagnosis. Impaired skin integrity related to vascular insufficiency. The goal is to maintain the integrity of the patient's skin. This is the following nursing interventions. Assess skin integrity, record changes in turgor, color noise, local warmth, erythema excoriation, assess the extremities for venous obvious protrusion, Change in position often and avoid massaging the affected limb. Range of motion exercises help to passive or active. Perform warm compresses and moist heat to the extremities or the hospital if indicated.